Now move on to our second clinical case presentation, focusing on paraganglioma in pregnancy. It's a very complex and rare condition, but I'll leave it to Dr. Hieu Tran to present on the case. She's from the Department of Endocrinology at University Medical Center, Ho Chi Minh City, Vietnam. And the session will be moderated by Dr. Tran. He's the secretary of ANAH, and he's also the deputy head of the Department of Endocrinology at the same institution. Please join me in welcoming Dr. Hieu and Dr. Thang. Thank you.
Thank you, Yiling. Hello, everyone. So thank you for having me today. So I'm going to present a case of paraganglioma in pregnancy. And this is the abbreviation that I'm going to use for my slide. So this is a very young, sorry, I'm just going to lose this first. This is a young female, 32 years old, so G1B0. So she generally well before this pregnancy. So she preferred to see us in endocrinology from cardiology for evaluation of a suspicious right adrenal tumor identified on the abdominal ultrasound during the assessment for young hypertension diagnosed at 7 weeks of this first pregnancy. So back to the history timeline, 3 months prior to this, the patient reported having intermittent episodes of the non-exertional shortness of breath, lasting for about 5 to 15 minutes. No blood pressure check at this point, and she was diagnosed with the post-COVID-19 syndrome without any treatment. A month later, the patient conceived a baby. At the prenatal checkup at 7 weeks of pregnancy, her blood pressure noticed 160 over 100. And the patient was diagnosed with hypertension, and she was giving metoprolol 15 milligrams every morning with no improvement. The patient also have indication to do the 24-hour Holter blood pressure. And as you can see, there's a fluctuation in her blood pressure, with the highest BP being 220 over 100, mostly at night. And the lowest was about 130 over 50, and mostly on waking up. Her heart rate was about 80 to 110 beats per minute. So at 20 weeks of her pregnancy, she followed up with the obs and gynae, and she reported having now another symptom of headache, nausea, dizziness, and several episodes of fainting lasting about 2 or 3 minutes. And the systolic blood pressure at the date of the follow-up was 110 to 120. And the ob and gynae decided to stop the metoprolol for the patient because of the episodes of the fainting for her. And the patient after that self-referred to the outpatient cardiology as our hospital, seeking for a second opinion. So at the cardiology outpatient clinic, her blood pressure now, as you can see, is urgent hypertension with blood pressure more than 200. The patient now treated with nifedipine for blood pressure control. And the cardiologist also initiated a workup for young hypertension. And the result just only came back about 1 or 2 weeks after that. So as you can see, her full blood count, the renal panel, electrolyte, liver function test, thyroid function test, all of this is within the normal range of the normal population, not pregnancy. The patient didn't have proteinuria. And in terms of the hormone level-wise, the plasma metanephrine were within a normal range, but then the plasma normetanephrine were elevated more than 20 times of the upper normal limit. The aldosterone and the renin is high as well. However, the cortisone were normal, then no renal artery stenosis. And in the abdominal ultrasound done for the patient, they suspicious that there's a right adrenal tumor. So at this time, the patient told us that she has a family history of the younger brother has a papillary thyroid carcinoma, and her grandmom in the modest size has a sudden death at age of 60. So the patient will refer to endo for further evaluation and management. So we admitted her for blood pressure control and also to organize the MRI abdomen for the patient. So on admission, her blood pressure, where as you see, like sometimes it's 100 over 60, and then later when come back, it's measured as 200 over 130. However, she has no postural hypertension, no Cushing-Goy, no proximal myopathy, no fetal edema, and other systematic examination was unremarkable. The fetal ultrasound now shows signs of the intrauterine growth restriction, and this now is at week 29 of her pregnancy already. And before that, all of the fetal ultrasound were normal. So our impression is maybe this BPGL with uncontrolled blood pressure and IUGR. So we started straight away the doxycycline 1 milligram twice a day, and the MRI abdomen later on were done on the patient. And there are two detected lesions, as you can see in the MRI. So the first one, the one that they say that they thought that is a right adrenal tumor on the abdominal ultrasound, were actually a retroperitoneal mass. And this one with the largest diameter of 6 centimeters is displayed the IVC and the right renal artery anteriorly. And then in the MRI abdomen, we also thought that there's another left adrenal mass here, measuring about 1 times 2 centimeters. So the patient, as per standard management of the BPGL, so she has a doxycycline 2 milligram stat, and then after that, we optimize the doses based on the blood pressure. We added her on propranolol a couple of days after that, and we also continue the nifedipine for this patient. We encourage the SON diet and fluid intake. So adrenal MDM was done at this point, and the plan were to aim for elective C-section at 36 or 38 weeks of pregnancy, followed by a removal of the BPGL at 6 or 8 weeks postpartum. So she underwent an eventfully elective C-section at 36 weeks of pregnancy, mostly because of the size of the intrauterine growth restriction. So she gave birth of the baby boy of almost 2 kg with the Apgar score of 7, no respiratory distress. So the mom, after the C-section, she actually did better in terms of the blood pressure control. She got discharged home 3 days after the C-section. So follow up 1 month later, we performed the scan of the CT chest, abdomen, and pelvis for her. So just to share that in Vietnam, we don't have the total scan. So that's why, like most of the outpatient with BPGL, we try to do it as a chest abdomen pelvic scan to screen if the patient have any tumor elsewhere. So the CT chest abdomen pelvic scan confirmed the retroperitoneal mass that we saw previously on the MRI. And again, as you can see, same thing is displayed the IVC and the right renal artery anteriorly, and it's pushing the abdominal aorta to the left significantly here. You can see that this tumor has multiple blood vessels that supply, that nourish this tumor as well. And these vessels can form small branches of the abdominal aorta. So the previous MRI finding of the left adrenal tumor, after we did the CT scan, we now confirmed that it's only an illusion. So it's very interesting in this case because after this CT chest, abdomen, and pelvis, there's multiple adrenal MDM were done, mostly because first thing, this is the size of the tumor. It's actually 6 centimeters. A second thing is, as you can see, this tumor was surrounded by multiple major arteries in the abdomen. So not many surgeons are confident of like operate in this case because of a very high risk of bleeding and high risk of operation. So finally, we decided to do the transcatheter artery embolization for this patient, thanks to radiologists and interventional radiologists. So they figure out that there are 2 main blood supply to this tumor. One is from the inferior aorta, and another one is from one of the branch from the intercostal artery. So they decided to block the 2 sides of the 2 main blood supply. And this is how it looks like in the DSA. So after the embolization, this is how the tumor appear on the DSA. So 2 days after that, the patient underwent the open removal of the BPGL. This is her intra-op that I attended with the surgeon and anesthetic. So the total blood loss for this case patient was only 300 milliliters, and the total operation time for her was 3 hours. So this is how we set up in the operation theater for BPGL case. So we have IV fluid for the patient, and also all the standby medication just in case of any complication of the operation for the BPGL may occur. We got the GTN, noradrenaline, and nicapipine. And the macro and the microscopic appearance of the tumor, as you can see, is confirmed of the paraganglioma. So after that, post of follow-up, her blood pressure normalized without any antihypertensive medication. The genetic testing came back with not what we expect is the no germline mutation, and this is all the gene that they tested for this case. And her plasma metanephrine would normalize after the operation. And she's now having an annual follow-up with plasma metanephrine now. And here are some of the discussion points that we put for the case, and I'm going to turn this to Dr. Thang.
Thank you, Dr. Hieu, for the excellent and detailed presentation. The case you presented highlight the complexities of managing PPGL in pregnancy, particularly the challenges in diagnosis and treatment planning. So, Troy, from your experience, what are the critical factors to differentiate between the gestational hypertension, the preeclampsia, and PPGL in such case?
I think this is, I think crucially in this patient, there was symptoms before the pregnancy, and I think that really helps, obviously, to differentiate between gestational hypertension and whether there's chronic hypertension. The presence of symptoms were very helpful, and even in a patient with hypertension, I think we can safely perform plasma metanephrines and 24-hour urinary metanephrines, and like Professor Bill said, the overlap between patients with a symptomatic disease and who are normal, actually there's very little overlap, and patients with PPGLs are much higher. Yeah, I thought it was quite interesting about the peri-op management, and I do wonder, after surgery, was the need for, after pregnancy, after delivery, were the medications reduced, or did they increase? And I wanted to hear what Professor Bill Young has in his experience with the pregnant patients, whether it's before, whether they operate before, after surgery, and the need for medications.
Yeah, so I'd be glad to weigh in. I think this patient was managed beautifully. The most important thing is to recognize that the patient actually has a catecholamine screening tumor in pregnancy. We completed a multi-center international cohort design publication a couple years ago, and the patients that did not do well were those that were not recognized to have a catecholamine screening tumor in pregnancy. That was the number one cause of fetal demise and major complications in the mother. But once it was recognized and these patients were put on appropriate adrenergic blockade, that was what led to the best outcomes. So I think this patient was managed excellently during pregnancy. You saved her life, you saved the baby's life. I do have to say that the choice of management with ablation was rather bold. I guess my question would be, what happened that day to blood pressure? Because when you do a ablation like that, embolization of a catecholamine secreting tumor, typically there's quite a bit of release of catecholamines. So when we've done such a procedure, we've prepped the patient with alpha-methylparatyrosine or met-tyrosine or Demzer, and this depletes the tumor of the stores of catechols and makes such a procedure safer. So I'd like to hear what it was like in the procedure room that day.
I think I can add on a little bit. So on the day of the embolization, actually there are lots of concern and discussion as well, because it's quite rare that we do such thing for the BPGL. So it's really my first case experiencing this. So there's no spell intra-op for the embolization. And I think the discussion point, one of other discussion point that we make for this is like after the embolization, when we're going to do the open removal. Is it like within 3 days or within 5 days? And what we're going to monitor in that 3 or 5 days? Like, do we need to look at the cortisol level to make sure that we're not going to put the patient on the risk of, adrenal insufficiency, something like that? So there's a lot of things to consider behind the scene. But in terms of the spell, as what I recall, there's no spell during the intra-op for embolization. I think it's because that we block the patient before, and it's really done after the postpartum. So I think like after the elective C-section, I think we remove one of the trigger, like one of stress factor for the patient. So maybe it's work in that way.
Can I ask a question about how long postpartum do you wait for these kind of cases to let the effects of the pregnancy kind of like,
Yeah.
is it 6 weeks then you do it? I mean, is that the magic number? I'm just curious. And because it grew quite a bit during pregnancy, right? It went from what to 6? I can't remember what the size change was.
I think the size is the same.
Okay.
But I think Dr. Thang can tell about like why 6 or 8 weeks. I not quite sure. But then after that, it took a very long time to convince surgeon to go operation is the first thing.
6 to 8 weeks postpartum, but somehow the patient get like reluctant to do the surgery because her baby is still very small. So actually 1 month later, so around 3 months postpartum, the patient agreed to go ahead with the surgery. So actually we can proceed with the surgery at that time. And your end, you got any comment on like the gene screening?
This
Because
happens
this
a lot.
one is negative.
I guess this happens that's why it's only like 40%, right? Because 60% will come back negative. But she is 32, and it was retroparent. I was gonna say, as you were showing the slides, I was like, okay, I was looking through the other scans. Were there any hemangioblastomas hiding anywhere? Were there other things to suggest VHL? I didn't see it. So I was thinking maybe SHB, right? Might be, and we do see sometimes the PTC in the brother has a PTC as well. So, but I am surprised that it is negative. I would have thought that she would come back positive, but this happens in 60% of the cases. But I would actually enroll, if possible, the family into research, because I think a male PTC is relatively uncommon compared to a female PTC. And then I think the mother also needed some workup, if I'm not wrong, as well. So yeah, I would have enrolled the family into research and try and find out, dig a bit more into this case.
Yeah, thank you for such an insightful discussion. I think the case highlights the critical role of multidiscipline collaboration and personalized care in achieve best outcome.